we have divided the conditions of inner ear into three parts. The conditions which involve both the cochlear and the vestibular part, hence the patients here present with hearing loss as well as vertigo. The second group is the ones which involve only the vestibular part, so the patients present with only one complaint, that is vertigo. And the third part is the one which involves only the cochlear part, where the patient presents only with hearing loss. So here we are doing the first group of conditions where the complete inner ear is involved. The presentation is because of involvement of both the cochlear and the vestibular part, where we have done the very major, very important condition of the inner ear, and that is the mean ears. Now in this module, we will be doing the rest of the conditions. So let us start with the next condition, and that is superior semicircular canal dehiscence. Now when I say superior semicircular canal dehiscence, it means that there is a dehiscence, a gaping, a gap in the bone overlying the superior semicircular canal. So where is the bulge of superior semicircular canal? Do we know that? Of course we know that. So where is the bulge of superior semicircular canal? Yes, the superior semicircular canal bulge is present. Here this is the petrous part of the temporal bone. The whole of the inner ear is present inside the petrous part of the temporal bone, and here on the anterior slant in this area is the bulge of the superior semicircular canal. So if it is dehiscent, if it is gaping, which can occur because of any trauma, or it can be present congenitally, so that is what we call as superior semicircular canal dehiscence syndrome, or it is known as third window. So it is known as third window, and yes, this bulge is what is known as the arcuate eminence, bulge of the superior semicircular canal. So this is known as third window. Why third window? Because normally we are supposed to have only two mobile windows. Which two mobile windows? The oval and the round window. So if we have an opening here, it becomes like a third mobile window, and that creates all the problem. So let us see, if at all there is a third mobile window, what will be the complaint that the patient will have? Yes, patient will have both cochlear as well as vestibular symptoms. So let us see what will be the symptoms. The vestibular symptoms first. Now, whenever there is a loud sound which goes from the middle ear into the inner ear. Okay, first tell me, will the loud sound stimulate the organ of Corti? Yes or no? Yes, the organ of Corti is for hearing. So, of course, it will be picked up by the organ of Corti. Can a loud sound also stimulate the utricle and saccule? Yes or no? Yes, we've seen that. We saw that when we did the physiology of the vestibular system, that whenever there is a loud sound, what happens in us? Whenever there is a loud sound of a gunshot or a bomb or very loud sound, somebody just shouts like this, yes? Yes, so what is this? This is because of stimulation of the utricle and saccule. Because of the saccule, from the saccule through the inferior vestibular nerve, the impulses go to the sternocleidomastoid, and this relaxation of the sternocleidomastoid occurs in response to loud sounds normally also. So yes, normally also the loud sounds, they go to stimulate the saccule, resulting in this reflex which is known as vestibulospinal reflex, to keep our body posture and head aligned. Now, what happens when there is an abnormal opening there? These loud sounds, they are able to abnormally hyperstimulate the labyrinth because of this abnormal movement of the endolymph here, because of another mobile window that will abnormally stimulate the superior semicircular canal, and they will stimulate it so much that it can lead to vertigo. So what will happen in patients if there is abnormal third mobile window at the superior semicircular canal? There will be vertigo on loud sounds. There will be vertigo on loud sounds. This reflex on loud sounds is normal, but vertigo on loud sounds is not normal. So much of hyper-excitability, if it is occurring, it means that there is an abnormal window or abnormal communication, because of which there is abnormal movement of endolymph stimulating the labyrinth. So vertigo on loud sounds, what is that known as? Do you know what it is known as? Yes, that is known as Tullio's phenomena. Tullio's phenomena. Similarly, also on external pressure changes, like on coughing, on sneezing, on lifting heavy weights, or when the intracranial pressure increases, like in Valsalva. What will happen? This pressure changes will again lead to abnormal movement of the endolymph because of that abnormal communication, and that will stimulate the inner ear, leading to vertigo. So there will be also vertigo on pressure changes. but I go on pressure changes like coughing, sneezing, lifting heavy weights, Valsalva. And what is this known as? Yes, this is what is known as Henne-Bird sign. Henne-Bird sign. But I go on pressure changes without a fistula on the medial wall. Here there is no fistula on the medial wall. That is what is known as Henne-Bird sign. So yes, patient will have, because of vestibular stimulation, the vestibular system getting abnormally sensitive to the pressure changes and loud sounds, patient will have Toulouse phenomena, patient will have Henne-Bird sign. Now, what will be the cochlear symptoms? Will there be any cochlear symptoms also? Will the hearing also be affected in this patient? Yes. So, what will be the cochlear symptoms? Let us see. Now, here in this patient, let us see what happens to the bone conduction sounds. Yes, bone conduction sounds. Now, we have abnormal opening where? In the bone. In the bone covering the labyrinth. So, it is a abnormal extra opening through which all the bone conduction sounds of a body can enter the inner ear excessively. What are the bone conduction sounds whenever we are speaking? This sound is going through the vibration of the external auditory canal also into the inner ear. The vibration is also going through the skull vibration into the inner ear to stimulate the inner ear. So this is usually not perceived by us. But now this sound will go excessively into the inner ear because of that opening in the bony labyrinth, and these sounds, and when the patient is speaking, that sounds will appear abnormally loud to the patients. That is what is known as autophony. Autophony. Not only this, even minor sounds like movement of the eyes inside the eyeball, the footsteps, all these sounds which are conducted through the bone of the skeleton, they will now abnormally be transmitted into the inner ear, and these sounds which we usually never hear, they will be perceived by the patient. So patient will hear his footsteps. Footsteps, not as the footsteps that we hear when we walk on the ground, not that much, but it will be loud. Every step that he takes, it will be heard very loudly in his ear. His footsteps, his eyeball, his eye movement, all this he will perceive excessively. But what will happen to the air conduction sounds? The air conduction sounds means the sounds which are going through the conductive pathway, through the external ear and then through the middle ear and then to the inner ear. What will happen to those sounds? Let us see. Yes. So these sounds which are going from the middle ear and then they are going into the inner ear. Now see, before they reach the organ of Corti, to stimulate it, some sound will get lost through this opening. Yes, just see here, when the sound is going from here, it will get lost because of this opening inside, which means that less of sound will reach the organ of Corti. So the organ of Corti will perceive as that the sound that is reaching, the defect is before the organ of Corti, that is leading to the sound, less of sound reaching the organ of Corti. That will be perceived as that there is some pathology before the organ of Corti. So what is before the organ of Corti? That is the conductive pathway. So it will be perceived as a conductive hearing loss. Now listen to this again. Now suppose there is a 100 decibel sound that we are giving to this patient, okay, 100 decibel sound. Now let us see what happens when there is a conductive hearing loss. Conductive hearing loss means there is any defect in the external auditory canal or in the middle ear. So now what happens is that because of this defect in the external auditory canal or in the middle ear, 40 decibel, suppose it gets lost. So now 40 decibel is lost and only 60 decibel sound reaches the inner ear. If there is a conductive hearing loss, only 60 decibel sound will reach the organ of Corti. Is that clear? That is clear? Yes, okay. Now, what happens if there is a dehiscence in the superior semicircular canal and we are giving a 100 decibel sound? So now when we are giving a 100 decibel sound, the sound when it reaches the inner ear, because of this abnormal opening, it gets lost. So suppose the 40 decibel gets lost here. Now again what is happening is 60 decibel is being sensed by the organ of Corti. So when we test the organ of Corti function, organ of Corti is functioning normally. The function of the organ of Corti is normal, but it is showing that the less of sound has reached the organ of Corti. That indicates that the pathology is before the organ of Corti. So that will be manifested as a conductive hearing loss. Yes. So when we test this patient, When we test this patient for the bone conduction sounds, the patient will be hearing so nicely. But when we test the air conduction, patient will be hearing less. Usually what is good? Air conduction is good or bone conduction is good? Yes, usually the air conduction is better than the bone conduction. Now in this patient, when we test the bone conduction is coming as better than the air conduction. So if bone conduction is good, bone conduction is a measure of sensorineural pathway. So that indicates that the sensorineural pathway is good. Where is the defect? The defect is in the conductive pathway, which means what I just said is that when we test the bone conduction is a measure of sensorineural pathway. What is air conduction a measure of? It is a measure of conductive plus sensorineural pathway. Conductive plus sensorineural pathway. So when we are testing the bone conduction, it is good. If bone conduction is very good, it indicates what? That the sensorineural pathway is good. So where is the defect? The conductive defect. Yes. So that is what creates the problem here. Patient has come to you with a complaint that he is hearing his sounds excessively. There is autophony. Even his eye movement, footsteps he is hearing. These are normally not to be heard. The eye movements, the footsteps, that itself should give you the indication that this can be a superior semicircular canal dehiscence. Yes. So if this has come to your mind also, then what are you expecting on the finding on when you do the tuning fork test? Yes. So when you do the tuning fork test, what you will see is that the bone conduction, he is perceiving very nicely. Air conduction, he is not perceiving. So when the bone conduction is better than air conduction, what do you label it as? Reni's negative. Reni's is negative, and that indicates that the patient has a conductive hearing loss. But does the patient have a conductive hearing loss? No, the patient does not have actually any defect in the conductive pathway. But the hearing loss that has come is conductive hearing loss. Why? Because there is a loss of the sound before the organ of Corti because of that defect in the roof of the superior semicircular canal. Is that clear? Is that very clear? Why the patient has conductive hearing loss? And this is a repeated question of your exam, that in superior semicircular canal dehiscence, what is the hearing loss? So the hearing loss, there is not sensorineural. Don't mistake that. It is a conductive hearing loss. So here is a patient who has come to you with all these complaints that whenever he coughs, sneezes, or whenever there is any external pressure changes or loud noises, that leads to vertigo in him. Yes, he will tell that I cannot tolerate my child shouting. I cannot tolerate the TV which is loud, and any sharp, loud noise, it gives me vertigo. Yes, so don't think that he is malingering. This can be the feature. This is what is known as Tullio's phenomena. This is what is known as Henneberg sign. So whenever patients complain of this, always think that is there some abnormal communication through which these sounds, which usually, these pressure changes, which usually are not supposed to stimulate the inner ear, they are stimulating the inner ear. Okay, so patient has come to you with these complaints, and yes, also he's telling you that I get so disturbed, even I can hear my eye movement, I can hear my footsteps. So all this raises a suspicion in your mind that this can be a superior semicircular canal dehiscence, and now you want to confirm whether it is superior semicircular canal dehiscence or not. You know that yes, in this patient what will happen is bone conduction sounds will be excessive. So you take out your tuning fork and you test for the Reni's. So when you test the Reni's, what you see is bone conduction is very good, air conduction is not good. Yes, so Reni's will be negative. Reni's will be negative. Yes, so when you do, and yes, the Weber's sound, because of the opening, because of the bone conduction, it will be excessively heard in this. So Weber's will be lateralized to the same ear, to the defective ear, to the worst ear. So yes, that is what you are expecting in this patient. And when you get an audiogram done, that is exactly what will show. What will it show? The audiogram, it will show that, see the bone conduction. Normally usually what we see is that up till 0 decibel is what we consider as a normal reference of when the hearing of the patient is same as the reference that we consider as normal, that is 0 decibel. Here what you are seeing is, see, the bone conduction is even better than that. Bone conduction sound is very good, whereas the air conduction is a little defective. So yes, that is what you are expecting here. So that is, if anybody will just see this audiogram, they will tell that this patient has a conductive hearing loss. Yes, the patient has conductive hearing loss. Why? Because the defect, conductive hearing loss obviously means what? Defect is in the external ear or it is in the middle ear. Defect is in the middle ear. So there is conductive hearing loss. But does this patient have a conductive hearing loss? Yes or no? You have had a look at his tympanic membrane. Up till tympanic membrane, everything is normal. Where is the defect? The defect is in the superior semicircular canal roof. So will there be any pathology in the external ear? Up till the tympanic membrane, everything will appear normal. So then to confirm that this patient does not have any defect in the middle ear, because of which this hearing loss, conductive hearing loss is there. What can you do? Yes, how do we test the condition of the middle ear, which what test? Tympanometry. So if there is, yes, in the tympanometry, if there is any defect in the middle ear, that will show us some abnormal curve. But here, because the middle ear is normal, it will show what curve? It will show a curve on tympanometry. So the tympanometry will be absolutely normal. Tympanometry will be A type. So that will tell you that the middle ear is normal. The middle ear is normal, and the bone conduction that is increased. The hearing loss, which is conductive hearing loss, is not because of middle ear. It is because of a superior semicircular canal dehiscence, and then is when you go for a HRCT to confirm. So you confirm it by a high resolution CT. Yes, as we are seeing here, can you see this defect? This bone which overlies the superior semicircular canal, this has become so thin here. It is almost missing in this area. So then you confirm that this is superior semicircular canal dehiscence. Now another test we have which can tell us that yes, the inner ear is becoming hyperexcitable to sound, and that can be a feature of superior semicircular canal dehiscence. That is what is Wemp test. So yes, Wemp test is very, very important in this condition. What is Wemp? Yes, we know that normally also the saccule, the inner ear, the saccule and the utricle, they get stimulated by loud sound. When there is a loud sound at the footplate of stapes, because of the movement of the footplate of stapes a little more, the utricle and the saccule, they get stimulated. They get stimulated but little. They do not get stimulated so much that they will lead to vertigo. They get stimulated only little, only that much that they can maintain the posture of the head and the body. So for this, from the saccule through the inferior vestibular nerve, the impulses go to the same side, sternocleidomastoid. I told you, how can you remember that? Yes, from saccule is to sternocleidomastoid. Yes, and that leads to a relaxation of the sternocleidomastoid. That leads to a relaxation of the sternocleidomastoid. So now what will happen when loud sound, when you give loud sound and you check for Wemp, in us also the Wemp will be the vestibular evoked myogenic potential. This is known as vestibular evoked myogenic potential. That will be present in us also. But in people in whom there is hyperexcitability because of a dehiscence, because of a third window, in them what will happen is the amplitude of the waves, which is normally this much, the amplitude will increase. The response that we get from the muscle will be excessive when you give a loud sound. Also, when we give even not a very loud sound, which normally in anybody will not elicit this response, in them also this response will be elicited. So the threshold of sound which elicits Wemp is reduced. So if in us 80 decibel sound leads to Wemp, in them in whom there is abnormal communication, the labyrinth will become hyperexcitable. In them, even a 50 decibel sound will lead to eliciting of Wemp. So this Wemp test has been asked in your exams in relation to the superior semicircular canal, and this is how in superior semicircular canal by Wemp we find out that yes, it has become hyperexcitable to sound. So once we have confirmed in this patient by a HRCT of the temporal bone, HRCT of the temporal bone, that yes, this is the confirmatory test that this patient has a third window at the superior semicircular canal. How are you going to manage this patient? Yes, we know that all this stimulation, all this problem is because of the abnormal window. So what do you repair it? So the definitive management is repair it. If the patient is very much troubled. But if the patient is not very troubled, why? Because is the patient having vertigo all the time? No, only on loud sounds, only on pressure changes. Yes. So if the patient is not very, very troubled, then in that case, you can just leave it also. You can just leave it behind, nothing to do. But if the patient is disturbed, in that case, we can go for repair of the deficit, repair of the defect. Another condition which can make the inner ear very hyperexcitable to loud sounds or to pressure changes is whenever there is a fistula on the medial wall. So that is what we call as a perilymph fistula. The medial wall of the middle ear, as we can see here, that is the common wall between the middle ear and the inner ear. So if there is any fistula on this medial wall, that will also make the inner ear hyper excitable and responsive to loud noises as well as to pressure changes. So first of all, you are going to tell me that if there is a fistula on the medial wall, what has caused this fistula? What can be the cause of a perilymphatic or a perilymph fistula? Yes, so whenever there is a fistula on the medial wall, we call it as a perilymph fistula because that can lead to leakage of perilymph from the inner ear into the middle ear, and it can be caused either because of any disease of the middle ear. Tell me any disease which can lead to erosion and that can lead to a fistula. Yes, very good. It can be because of cholesteatoma. Or it can occur because of trauma. And what trauma? What trauma? The trauma can be, very commonly, it can be a surgical trauma. Surgical trauma, which surgery? Can you tell me any surgery that we do specifically on the medial wall? Yes, on the oval window, which can lead to a fistula. Yes, stepidotomy. So that is a very important cause of perilymph fistula. Stepidotomy or stepidectomy. Or it can be because of a non-iatrogenic or non-surgical trauma. This non-surgical trauma very commonly is a barotrauma. Barotrauma. Yes, when we did barotrauma, we saw that because of sudden pressure changes, there can be increase of pressure of the middle ear or very, very decrease of pressure of the middle ear, which can lead to fistula occurring at the round window. It can lead to fistula occurring at the oval window. So yes, all these are the causes of perilymph fistula. Now, can you tell me any surgery where specifically we were making a fistula on the medial wall? Do you remember that? Yes, so yes, on the medial wall, we have these stapes and it was getting fixed in some condition, yes, in autostenosis. So surgeons, before stepidotomy was invented, surgeons thought that this is got fixed. Now, how will the sound go inside? What they saw was there is a bulge here. They made an opening here. What is this a bulge of? Yes, a lateral semicircular canal. So what they are doing? They are making a fistula on the medial wall. This led to the inner ear becoming hyperexcitable to loud sounds, hyperexcitable to pressure changes, causing vertigo in the patient on loud sounds and on pressure changes. So that is why this surgery, which was known as making a fenestra over the lateral semicircular canal or fenestration operation, has been discontinued. It is abandoned now. It is no more done. Yes, but so we know that yes, what happens here is we are creating a fistula. So now we know that whenever there is a fistula, what can be the cause of fistula? We know that. Yes, so whenever there is a fistula, now what will happen to the patient? Same. Whenever there is a loud sound, now there is a abnormal communication or direct communication between the middle ear and inner ear, through which that loud sound can excessively go into the inner ear. When there are pressure changes in the middle ear, same, because of coughing, because of sneezing, because of lifting heavy weights, all this will excessively go into the inner ear and that will lead to vertigo. So yes, in this patient will have vertigo on loud sounds. What is that known as? Tullius phenomena. Patient will have the presenting features. Yes, patient will have vertigo on pressure changes. Vertigo on pressure changes. So the moment you do the fistula test will be positive. Fistula test will be positive. And very, very important, when will you suspect perilymphatic fistula? Yes, whenever any question is given specifically before the onset of this Tullius phenomena, before the onset of vertigo on pressure changes, always there will be a history given, history of any surgery or history of barotrauma, history of trauma will be given. It is only then, or history of otitis media. All this will be present, only then you are going to think of perilymphatic fistula. This is not a congenital anomaly that it might be present in anybody without all this history also. So will there be any cochlear features also? Will the patient also have hearing loss? Yes or no? Yes, just see here what is happening here is there is abnormal fistula. So because of the fistula, what happens is that the perilymph can leak. Perilymph can leak into the middle ear. So what will happen is there will be pressure changes in the inner ear compartments. Yes, that can lead to damage of the organ of Corti. So patient can have sensorineural hearing loss. Can the patient have only sensorineural hearing loss? What if it is because of cholesteatoma? Cholesteatoma is here and that is leading to the fistula. Patient already has a conductive hearing loss. Yes, so if there is a barotrauma because of which the ossicular chain has also got dislodged, so patient can have any type of hearing loss here. So in the cochlear features, patient can have hearing loss, and this hearing loss can be either a conductive hearing loss, it can be either a mixed hearing loss, or it can be a sensorineural hearing loss. And these patients, the sensorineural hearing loss initially can also be fluctuating. Why fluctuating? Yes, whenever the perilymph leaks, so then the pressure changes occur, that time patient has hearing loss. Later on it becomes better. Again, then when there is pressure changes and then there is more leak, then again there is hearing loss, or it can be a permanent type of hearing loss, sensorineural hearing loss also. So there can be any type of hearing loss that the patient can present. What is important for diagnosing is the previous history. The history of trauma suddenly leading to these symptoms, the history of ear discharge which is already present, and then suddenly these symptoms appear. So then we are going to suspect a perilymphatic fistula, and to diagnose a perilymphatic fistula, yes, you can go for a HRCT for diagnosing. You can go for a HRCT, but yes, many a times it is very minute and you can diagnose it only on exploring the middle ear. So that is what is known as exploratory tympanotomy. Tympanotomy means opening the tympanic cavity. So we do not open the tympanic cavity by giving an incision on the tympanic membrane. Here we raise the tympanic membrane. We do not want to damage the tympanic membrane. So we just raise the tympanic membrane and inspect the middle ear cavity. That is what is known as exploratory tympanotomy. And then we manage it by repairing the fistula. Repair of the fistula. So now quickly tell me, can a patient of Meniere's have Tullius phenomena, Hennebert sign? Meniere's, can there be stimulation of the inner ear by loud sounds and pressure changes? Yes or no? Yes, in Meniere's what we saw was that the utricle and saccule is dilated. It is very near to the oval window. So on loud sounds and on pressure changes, it can get stimulated. Yes or no? Yes. Can there be vertigo on loud sounds and pressure changes in a patient of superior semicircular canal dehiscence? Yes or no? Yes. In perilymphatic fistula? Yes or no? Yes. So when patient is having the same complaint in all three, how do you rule out whether it is a perilymphatic fistula, whether it is a third window, whether it is Meniere's? Yes, see, this is very, very simple. Don't get confused in this. There will be, if there is Hennebert sign given, if there is Tullius phenomena given, vertigo on all these things, you don't have to get confused at all. Yes, in Meniere's, the only presentation will not be Tullius phenomena and Hennebert sign. In Meniere's, when do you think of Meniere's? The vertigo is sudden onset, very severe vertigo, which is lasting for at least 20 minutes to 24 hours. Along with that, there is hearing loss, there is tinnitus, there is fullness in the ear, all that is present. That history is the main history. Along with that, this can be present. Yes, whereas, and if it is a Tullius phenomena or Hennebert sign because of the third window, the moment third window comes to your mind, very, very important feature is autophony. Autophony is there. There is increased bone conduction sounds, and very important, the hearing loss, there is a conductive hearing loss. And in perilymphatic fistula, yes, specifically the history of surgery is usually mentioned. History of barotrauma is usually mentioned, or of cholesteatoma is usually mentioned, following which the patient has this presentation. So let us quickly write down what the differences between these three conditions are. Yes, will there be vertigo in Meniere's? Yes, vertigo will be present in Meniere's. What will be the typical vertigo? That will be the first symptom, and that will be for 20 minutes to 24 hours. In superior semicircular canal dehiscence and fistula, will there be vertigo? Yes, it will be present. Yes, but it will be only only on, yes, Tullius phenomena, only this will be present, only on loud sounds, only on loud sounds or on pressure changes. Yes, so same here for fistula also, only on loud sounds and only on pressure changes. Whereas in Meniere's, the vertigo, continuous severe vertigo will be present. Along with that, Tullius phenomena will be present. Along with that, Henneberg sign will be present. So what will happen to the fistula test? So what is fistula test? Yes, when we press and release the tragus repeatedly, the pressure of the external aortic canal increases. It gets transmitted to the middle ear and then to the inner ear through a abnormal fistula on the medial wall. So if there is a fistula on the medial wall, fistula test will be positive. But in Meniere's and superior semicircular canal, is there a fistula on the medial wall? The pressure changes is going into the inner ear, stimulating the inner ear, but there is no fistula on the medial wall. So this test will be positive, but there actually is no fistula on the medial wall, so it is known as false positive fistula. So in Meniere's, it will be false positive. Here also it will be false positive. Yes, so quickly tell me, what will be the hearing loss in Meniere's? In Meniere's, yes, it is a sensorineural hearing loss. What frequency is affected early? Low frequency is affected early. Whereas in superior semicircular canal dehiscence, it is a conductive hearing loss. Very, very important, conductive hearing loss. This is a repeated incorrect choice when a MCQ is given, that whenever in superior semicircular canal is given, what is the incorrect choice that is given there? Patient has sensorineural hearing loss. So what hearing loss patient has is conductive hearing loss, not a sensorineural hearing loss. In fistula, it can be either conductive, it can be sensorineural, it can be mixed, it can be a conductive hearing loss. Usually it is mixed or it is sensorineural. So will the hearing loss be fluctuating in Meniere's? Yes, of course. We know in Meniere's the hearing loss is fluctuating only when there is vertigo, patient has hearing loss, and then it improves. In perilymphatic fistula, when there is leak of the perilymph, that time there is hearing loss because of pressure changes in the inner ear. Later on it improves. It can become progressive also, but yes, it can be fluctuating also. So here also it can be fluctuating, here also it can be fluctuating. In superior semicircular canal dehiscence, there is the hearing loss is not fluctuating. Here it is not fluctuating. History of trauma in Meniere's, no, it is not present. History of surgery, no. CSOM, no. Whereas in superior semicircular canal dehiscence, it can follow trauma. Yes, it can follow trauma, but history of surgery and CSOM, no. Whereas in fistula, it can follow trauma, it can follow surgery, it can follow otitis media. So yes, whenever there is any patient, grossly what we need to remember is that whenever there is any patient who has come to you with severe vertigo for few hours, which is not less than 20 minutes, not more than 24 hours, that cannot be a superior semicircular canal dehiscence, that cannot be a perilymph fistula. That has to be ruled out for Meniere's. Yes, only when the patient has pressure changes and vertigo and loud sounds, only then we need to think of abnormal communication, that can be a fistula or that can be superior semicircular canal dehiscence. The cochlear features in superior semicircular canal dehiscence is a conductive hearing loss. And how do you confirm that? That is by the HRCT. In superior semicircular canal dehiscence, very, very importantly, there will be the features of increased bone conduction, autophony. There will be loud sounds of his own body movements heard. And these are all the points that are asked in your exam. Now, another condition that can involve the whole of the inner ear leading to both hearing loss and vertigo is labyrinthitis. Labyrinthitis. And what is labyrinthitis? Yes, it is acute inflammation of the labyrinth. From where does the infection reach the inner ear? Yes, it can either reach the inner ear through the middle ear, following any cholesteatoma, following any fistula. If there is a patient who has had fistula, the infection of the middle ear can go into the inner ear leading to labyrinthitis, or yes, so it can be because of a fistula on the medial wall. The infection has gone into the inner ear, or it can occur through meningitis. So from the middle ear it can go, or it can come from the meninges. And this has been a repeated question. A patient of meningitis develops labyrinthitis. This has happened through. So if any meningitis is leading to labyrinthitis, this will happen through what? Yes, what are the communication between the inner ear and the cranium through which any infection can go either ways? Labyrinthitis can become meningitis, or meningitis can become labyrinthitis. Yes, either through the internal acoustic meatus or through cochlear aqueduct. Cochlear aqueduct is the connection between the inner ear and the CSF, through which CSF enters into the inner ear and forms perilymph. So through these two connections, any meningitis can become a labyrinthitis. So whenever patient has labyrinthitis, it is for understood that the labyrinthitis will involve the whole of the labyrinth. So patient will have vertigo also. Yes, patient will have hearing loss also. What hearing loss? Sensorineural hearing loss. And the vertigo here will be continuous vertigo. It is inflammation. It is infection of the whole of the labyrinth. So it will be a continuous vertigo at least for around 72 hours or more than 72 hours, at least 72 hours continuous. Yes, or more. Patient will have continuous vertigo, and here typically there will be a history of either meningitis before this episode, or this will be a patient of otitis media, following which the patient has developed vertigo which is continuous, lasting for, it can be minimum at least for, it is an infection, it will not subside very quickly. Yes, so it will last for at least 3 days. It will be there. It can be more, and it can take a long time to even if the patient is treated, this inner ear which has got damaged can take a long time to come back to normal. So there can be little dizziness, there can be little imbalance, mild imbalance, which will continue for months also. But this is what we need to know in labyrinthitis, how it can reach from the meninges into the inner ear, how it can reach from the middle ear into the inner ear, and what the symptoms will be. And yes, the management will be, if it has followed otitis media, then remove if it has followed otitis media, CSOM, then you have to go for MRM plus IV antibiotics. And if it has followed meningitis, then IV antibiotics. Okay, so now keep your pens down. Yes, sit straight. Yes, okay. So here is a patient who has come to you with sudden onset severe vertigo for the past 12 hours. Can it be Meniere's? Yes or no? Yes? Okay. Can it be a third window? Yes, no? No? Can it be a perilymphatic fistula? Yes, no? No? Can it be labyrinthitis? Yes, no? It can be labyrinthitis. Yes. Will a history of otitis media or be present in Meniere's? Does Meniere's follow otitis media? No. What mutation has been postulated in Meniere's? Mutation of short arm of chromosome 6. Meniere's is usually idiopathic. Okay, what's the type of hearing loss in Meniere's? What frequency is affected early in Meniere's? Low frequency. What's the type of hearing loss? Typical hearing loss. Fluctuating hearing loss. Yes, what is frequency distortion known as? Frequency distortion in Meniere's. Yes, that is diplaquesis. Abnormal loud sounds becoming abnormally loud, or intolerance to loud sounds is seen in Meniere's. What is that known as? Yes, recruitment. What is the best investigation with which you will diagnose that this is a patient of Meniere's? Electrocochleography. Which investigation will make you diagnose that this is a patient of third window? Yes, a HRCT. What will be the finding of VEMP, vestibular evoked myogenic potential in superior semicircular canal dehiscence? Yes, the threshold will be reduced. You will get VEMP responses even when the loudness is not very much. That shows that there is abnormal communication. Yes, be it fistula, be it a superior semicircular canal dehiscence. In both, because of abnormal communication, because of hyperexcitability of the labyrinth, because of the fistula, or because of the third window, VEMP will be, yes, the amplitude will be more. The response in the sternocleidomastoid, the amplitude will be more, and also the threshold, the loudness required for that response will be less. It will be elicited even at a less loud sounds. What is autophony? Autophony is seen in which condition? Increased bone conduction sounds is seen in which condition? Yes, in superior semicircular canal dehiscence. What is the hearing loss in superior semicircular canal dehiscence? It is a sensorineural hearing loss. True, false? No, it is conductive hearing loss. Can a meningitis become labyrinthitis? Can a labyrinthitis become meningitis? Yes or no? Yes. Through which communication? Internal acoustic meatus or through cochlear aqueduct? Endolymphatic sac decompression is a management of, yes, very good, of Meniere's. So now I hope that you know that the presentation of all these conditions is totally different, and whenever in a question it is given, you will not get confused now.